Okay, everybody. Hello, this is Don Self. Today we're going to be talking about analyzing the practice analytics of a practice. What our main goals are going to be trying, hopefully, to reduce the possibility of audits or identify whenever a practice has been audited or going to be audited. I have that happen a lot. Just happened this last week. On two different occasions, doctors call me and ask me questions, and I pull up their data without them knowing it on my computer because I have the data on my computer for every doctor in the country from what they submitted to Medicare and Claims to 2015, and all of that is on this computer. And I said, oh yeah, doctor, you were flagging audits when you used 99214 too often, or the only code you've used for hospital admits was 99223. So we need to take a look at your documentation because whenever Medicare asks for it, it's going to be too late at that point. So let's go ahead and take a look at it now. Okay, so that's going to be our main goal right here. We need to be protecting our practice. That's the whole goal behind this, because we have recovery audit contractors out there that are basically bounty hunters, no different than Steve McQueen was in a 1959 series called Wanted. We have relators out there that yes, you can call in for audio, Joy, by the way, on the same phone number that you received on that email. But we have bounty hunters out there trying to find doctors doing things wrong so they can turn them in. We have employees turning in doctors because they didn't get the raise, or because the doctor didn't show them enough respect, or the hospital was intentionally doing something illegal. So there's all kinds of bounties out there. We got key TAMs being filed. We got civil money penalties being assessed. This is very serious information, and this affects every practice. VAC auditors, by the way, that works for the recovery audit contractors, is typically the nurses and therapists who's paid to second guess the doctors. And that's not really fair, but that's exactly what's happening right here. In fact, 49% of hospital denials are appealed. Only half of hospital denials are appealed. And yet, almost 3 out of every 4 appeals that's being brought before an administrative law judge are overturned in favor of the hospital. I'm finding similar numbers with physician offices. But the thing is, do we trust these people that's auditing us to be fair or honest or truthful? When you stop and look at all of the lies that's been told by government employees, you take a look at the unemployment rate. They talk about the unemployment rate is this percentage or that percentage. Even that is a lie. All they're doing is counting in people that are still looking for a job. That's called the U6 numbers. That's totally misleading. The true unemployment rate in our country right now, well, last year was around 20%. Right now it's around 17% when you take the true numbers into effect. And we have the IRS being audited. We have the Clinton emails. We have just one after another. You really can't trust the government people. You have to be sure of what you're doing yourself just to be safe. Key TAMs. The most common form of Medicare fraud is being found as reimbursement. And that's like people billing for things that they didn't do, or upcoding, or billing for services that were rendered that's not truly billable by Medicare. I would say probably, in my opinion, 80% of primary care physicians have been billing Medicare for services that Medicare should not have been billed for. 80%, 8 out of 10 doctors that I'm talking to right now have done this in the past. As a good example, most offices, they've been billing annual physicals. Medicare has never paid for an annual physical in the office, yet they'll bill it out as a sick visit. And yet that's not what an annual physical is. And yet we find that that's going on. And doctors are getting caught on these things. And unfortunately, all it takes is one employee to turn them in. Now, I'm not saying that every doctor is doing this on purpose. In fact, I think probably the percentage of doctors that's intentionally committing fraud is probably very, very low. We're probably less than 2% of the doctors in the country. But it doesn't require that there be intentional fraud for Medicare, CMS, and the Department of Justice to come after you. It can be in what's the word I'm looking for? I know ever since the heart attack, I'm having trouble remembering some words, but no, I didn't have a stroke. It can be accidental. that they billed something that they shouldn't have. In other words, whether you intended to commit fraud or not, they're still going to apply the same penalties and civil money penalties to you and fines. You just won't end up getting the jail time, because in order to get the jail time, they have to prove that you intended to do fraud. Now, I know it sounds like I'm kind of scaring you right here. So let's talk about this. There's really two ways to review a practice. I can pull up the procedure code frequency report in a doctor's office, and it shows me all of their patients. So I'll ask the doctors to send this to me. And it doesn't give me the patient names, it just shows me a procedure frequency report showing every code and how many times each code was billed. That's the best way to do it. In some practices, I'll be talking to a practice and they don't know I'll do it. I'll pull up the same report, but it's only on the Medicare Part B patients. So it doesn't even include the Advantage Medicare claims. But it'll show me all the codes that they billed Medicare in a specific year and that Medicare paid for. And it tells me how many times each code was billed and data. For instance, this is what I'm showing you here is a report from a physician office. And it had other columns, but these were the main ones. It shows me every procedure code, how much they billed out, how much they received in payments, how much adjustments, and how many times they billed every code. And looking at this, I can scroll down and see, okay, wow, this particular practice right here billed out 822 ABIs to Medicare, ankle brachial indices. They did 1,304 EKGs. They did 308 rhythm strips. They didn't bill out any spirometries. They didn't bill out any level 2 or segmental ABIs, etc. This is the kind of data that I get excited about. It's like a doctor when they look at a CBC, how much information it tells them. This tells me a lot about the health of a practice and how well they're billing. I prefer it to be sorted out numerically like this. Then I can combine and look at this and say, okay, at a quick glance, this practice billed 576 level 3s, only 19 level 4s, and no level 5 new patient visits. Or this particular practice did not bill out any ICU or critical care visits, which can be done in any place of service. They did bill out 3,127 times for poking patients with a needle for administration of IV injection, when they billed out for 71 times for 96103, which is a cognitive test. These are the kind of things that really helps. I do notice in this particular case, they only billed out for 1 annual wellness visit initial and 3 repeat annual wellness visits. That's not a lot. So this helps me in a physician office know about what's going on. So what am I looking for? What should you be looking for whenever you're doing looking at the practice analysis or looking at the Medicare data reports? Well, the first thing I look at is audit potential. Are they billing for services that we know is on the OIG watch list? Every year, the Office of Inspector General, that's the Department of Justice division that looks out for Medicare, Medicaid, TRICARE, etc. They give you a work plan every year. Office of Inspector General says this is what we're looking at for physician offices. And you can go to their website on the oig.hhs.gov website and look at it. And by the way, at the end of this webinar, you're going to get an email asking you to complete a little survey. I think it's like 7 or 8 questions about this. And then once you complete it, it will automatically send you out a PDF, and you'll have a PDF image of every one of the slides you're seeing right now. That way you're not having to hit Control-Alt-4 or copy or draw notes as much as you would have to, because you're going to get every image I'm showing you today. So what's on the OIG watch list? That's what we're looking for, because we know that commercial carriers are going to follow Medicare and OIG. They've been doing that since 1989. Prior to 1989, Medicare followed the commercial carriers. For some of you wondering, well, what happened in 1989? Well, 1989 is whenever the government came out and said it was at the end of what's called the fee freeze, and that's when they started the Medicare limited, no, maximum allowable actual charge. That's where the government came out and said you're limited on how much you can charge a patient. So with that in mind, commercial carriers said, wow, we can do that too. And they started things similar. So Medicare sets the trend now, and the other carriers follow. And in one way, that's good because Medicare rules are easy to figure out. They may change a lot, but that's okay. We know where to go to find them. Where commercial carriers can change daily. This day we're going to do that, that day we're going to do this. So when it comes to these audits, it's interesting to know that the commercial carriers follow Medicare usually by 2 to 3 years. Medicare starts doing something now within 2 years to maximum 3. The commercial carriers are doing the same thing. So one of the things we're looking for is billing out multiple units. This is on the OIG watch list. Billing out multiple units for the same 15-minute therapy if it's a timed code. For instance, we grab one right here from a doctor. This is a Dr. Richard Miles. I do not know Richard. He does not know me. He's in Detroit, Michigan. He's a family physician. He billed out code 97032, electrical stimulation, 168 times on 11 patients. He billed out 97112, neuromuscular reeducation, 1,023 times on 18 patients. Wow, that's a lot. And 97140 for manual therapy on 20 patients, 1,399 times. I mean, wow, that's a lot. So they're going to come back and ask this doctor for progress notes. And on the progress note, they're going to look to see how long this doctor had this patient on this device. A lot of device salespeople will tell a doctor, since we have multiple leads, then for every 15 minutes, you can bill code 97032 and 97140 and 97112 for every 15 minutes, all 3 codes. And if you do that, you're going to get yourself audited. You should not trust coding advice from just any salesperson coming in the door. They're going to try to make it look like your reimbursement is going to be huge. That way you'll want to buy it and they get to make their commission and they're on out the door to the next person. You should be trusting coding advice to people like me when billing people, and just make sure that you're following the good advice. That's one of the things we're looking for. Or what if a practice is billing all visits out at the highest level? Here's a doctor. I went ahead and changed the doctor's name in this particular case because this turned out to be one of my clients. And in this particular doctor right here, a family physician in Texas, had billed out 840 times for 99215, but you don't see any 99214, 213, 212, 211s. This doctor was definitely flagging audit. We cannot have every visit billed out at the same level. Even if you'll sit there and say, well, my doctor always bills everything as a level 3. I'm sorry, not every visit is a level 3, and that's incorrect coding. You should never code for reimbursement. You should code for the level of service that was documented and medically necessary. Sometimes we'll find that Medicare data is incorrect. For instance, this doctor right here in Tuscumbia, Alabama, was shown as a general practitioner, yet he was a board-certified internal medicine doctor. Now, why is that important? Does that mean he's going to make more money? If you go back to the period of prior to the relative value units, 92, whenever an internal medicine doctor had an allowed amount of this much, and a general physician had this much, and a general surgeon was way up here, and a cardiologist and neurologist was way up here, etc. Yeah, it made a difference. What this is going to make a difference on is making it, when you have the incorrect specialty is, they're going to compare this doctor's coding to others of the same specialty. In this particular case, this doctor is using 99214 most often. That's not the case for a general practitioner, specialty code 02. General practitioners generally use level 3 more than level 4. So this doctor is going to be an outlier in using the higher level codes, and that means you're going to audit this doctor more often. That's why it's important you understand what specialty code your doctor is. You say, well, how do I get this information right here? You can go to CMS's website and then download the file, which is what I did. It's a 2.2 gigabyte size file. The next question is, how do you open it? Well, you know Lotus 123 or Excel is not going to open a file that big. Excel will handle a maximum of 1,248,000 rows of information. Well, this particular file is 9.6 million rows of information. And if I remember correctly, it had 38 columns of information. So that's way too big for an Excel spreadsheet. You say, well, okay, what can I open it with? You can open it with Text Editor and then go through and try to find the data you're needing and using Text Editor and draw it out and make it into smaller files. You can also use Access if you have a Windows computer. If you don't have Access, you can buy that software. I believe it's less than $600. I have a Mac, so I use FileMaker Pro. And I believe that software was a little bit less than $500 if I remember correctly. But I use that to sort the data that I need, and that way I can handle a 9.6 million row file, 9.6 million rows of information. So that's how I break out this information. And you sit there and say, okay, Don, this is way over my head. I'm not going to try to go out and buy FileMaker Pro or Access or try to use TextEdit to go into a 9.6 million row information file and data pool. If you contact me, because I have spent the hours and hours and hours doing this, breaking it out and putting it into smaller files so I can work with it and getting it. If you have a particular client you're working with, I can pull that data up and share it with you. I'll make it a very reasonable fee. If I'm doing an analysis for your doctor, you want me to spend the time with your doctor, I'm not going to charge you for it. If I'm just doing it for you so that you can help your doctor, I have to charge a little bit. Since I'm only working so many hours a day right now due to the heart attack, my wife, like I said, she has me limited. My wife is making me charge for things in the past I've given away for free, and I don't like that because I prefer to give it away for free. But she's making me charge a little bit just so that we can pay the bills during this time whenever I'm not working as much. So forgive me, I don't mean to go off on my troubles, but I want to try to help you get that information if you can. Here's actual data from the 2015 submitted data to Medicare. And I just pulled up some doctors right here, and you said, so well, did you pull these doctors specifically? No, these were pulled at random, and I just scrolled down and said, okay, this doctor, the only code Frederick Wiegand in Deltona, Florida, billed to Medicare for initial hospital was 99223. He billed it 39 times. A Jennifer Caragall or Anita Gill or Emily. Now look at Emily Leisure. Emily Leisure, and you should be able to see the screen, hopefully a bit large on your screen. She billed out 99222 16 times, and she billed out 99223 18 times. She's in Minnesota, in Rochester. No, Emily doesn't know me. She doesn't know I have access to this data, but it's public data. Is she billing a higher level code than most internal medicine doctors? No, she's not, because I've already done an analysis, and I'll show you in just a moment here what the percentages are on initial hospital discharges, etc. She's right in line. But you go over here to Mumta Gupta, internal medicine, 18 times he billed, and the only initial hospital code that he billed was 99223. Or you go to this cardiologist. Now, sometimes doctors will say, well, every patient I see when I admit them into the hospital, I spend an hour going over that admit. And I do it because it's medically necessary. Well, if that was the case, why would every cardiologist in the country not do the same thing? Because they're going to compare your coding doctor to the average of other cardiologists, or other internal medicine, or other family physicians. You said to them, so well, how can I get that data? I have that data on my website in the 2014. It's very reasonable for the entire file. It covers all of the docs. You can download that data. I haven't run all the data for the 2015 because this came out just this week. The CMS released it. So I've only had this data for 5 days, and I'm still trying to get it all put together in the limited time I'm working. But I guarantee you, doctors like Bhavandeep Bajaj, internal medicine, every visit was this level 3. He flagged audits in 2015. Now, when will he be audited? Medicare is running 2, 3, sometimes 4 years behind. So he may not get a request if that's Bhavandeep is a male. He won't even get a request for this data, progress notes on these claims right here until 2018 or 2019. And by then, it'll be too late, because if he's been doing it this wrong here, guarantee he's still doing it wrong at 16 and 17 and 18. And that's what the ones that Medicare goes after. So you have to look for this kind of stuff. That's initial hospital. Think about it. Every one of these doctors billed out the only level they billed out. Every discharge that they billed out was a 99239. Are you going to tell me they didn't do any hospital discharges on any of their patients? That was a 99238. Now remember, 99239 is a timed code. What do you mean? That means it's 31 minutes or longer, and the doctor's progress note has to show, since it's a timed code, how long did the doctor spend. Now, Medicare is not going to require start and stop time on 99239, but they're going to require doctor write in on the progress note spent 41 minutes or 38 minutes or 34 minutes or whatever it is on hospital discharge. Because in the absence of that time being shown in the progress note, Medicare will automatically, and rightfully so, since the documentation is not there to support it, they will automatically downcode this doctor to a 99238, and then they're going to come back and ask for money back for the difference between the 38 and 39. You say, well, so what? What's that? I mean, what is that, $30 difference? Yeah, $30 difference. But Medicare could, if they wish to, assign civil money penalty, CMP, on it, and hit that doctor with $1,000, $2,000, even up to $5,000 for each claim. So instead of $34 difference, it might be $5,034 per claim. Wow. And this doctor billed this out 311 times on 302 patients. And if Dr. Oni did not document time 311 times $5,000, that's $150,000. Wow, that's a lot of money. They can do that, and they get away with it. That's why it's important that your doctors understand why the documentation is so important. So how do you know it's out of average? Like I said, I have on my website the data from 2014, and hopefully in the next 2 weeks I'll have time to compile all this data and run the procedure. But I guarantee you it's going to be within 1 to 2 percentage points of what I'm showing you on the 2014 data. It was less than 0.6 of a change from 2013 to 2014. So it's going to be less than 1% difference between 2014 and 15. But I'll get that on my website so you can go in there and order it. But internal medicine, for instance, will use 99238 43% of the time and 99239 57%. So what's going to flag an audit? Well, if you're 10% above these averages for your specialty, then you're going to flag an audit. Like, for instance, family physicians use 99238 most often. Gastroenterologists, I don't know why, but they've been using 99238, and as do neurologists most often. So if your doctor is using, and he's a gastro or she's a gastroenterologist that you're billing for, or you work for, you're the manager for, or you're the doctor, and you've been using 99239, say 60% of the time, that's more than 10% above 30%, because 10% above 30 would be 33%. Well, that means you're going to automatically flag an audit, and the recovery audit contractors are going to start requesting records from you. Again, it might not be for 3 or 4 years after you did the service. And by then, you'd been doing it all this time, so they could come back and ask for a lot of money. I've seen doctors get nailed for over $1 million. I've seen a doctor in Georgia nailed for over $2 million. And that doctor did nothing wrong, but he got an overzealous auditor who would not listen to reason. Now, that doctor's still appealing that in civil court now, but at the same time, that was a huge amount of money to take a loss on. And before you start thinking, oh crap, I'm going to run away from Medicare, I'm just going to do like so many doctors have done and follow stupid advice from associations like the Texas Medical Association or specific osteopathic association out west, and I'm going to stop seeing Medicare patients. Think about it. Since the advent of the progress of HIPAA, commercial carriers can audit you the same way Medicare can. And the civil courts are assigning the same kind of penalties. So it's not just Medicare. If you're in this business, you better do it right. So how do you calculate the percentage? Well, you can take the total area. So like take all the number of times you billed out 99211, 212, 213, 214 this year to date. This is July, coming up on July 1st. So the first 6 months of this year. Total that up. Then let's say we have 1,346 total codes billed out. And if you want to find out what 99211 was, you divide that by the total number, and that gives you 9%. And then you can see where your bell curve is. It's not that difficult to do. I do it every day with spreadsheets. It's real easy. Now, every specialty, doesn't matter what specialty you pick, I went through and just started grabbing some from different specialties, have doctors that will bill the highest level codes way higher or much higher or extremely higher than their average. For instance, Joshua Todd. Again, I don't know Joshua, Knoxville, Tennessee. This is data I pulled off 2 days ago from the report. So Joshua doesn't know me. I don't know him. But again, this is public data. But at 99214, 319 times. 99213, only 22. He's way above the average. Cardiology. Conroe Hussein Amani, way above the average. Look at Kenneth Sabatino in Clearwater, Florida. 1,374 visits at level 4, only 67 at level 3 for established patients. How does that compare to the national average for cardiologists? Well, it is much higher, very much higher. Mark Pace, and it's not just cardiologists, family physicians. Here's Dr. Alner Q, family physician in Fort Meade. 913 visits at level 4, 286 level 3. 910 in Crittenden, Kentucky for Dr. Patel. Do you think these doctors know that I'm telling you so? No. Do you think that they know that auditors out there can just pull the same data? More important than that, then you could have bounty hunters out there pull this data and then report it and get an attorney to help them report it and file key tams against this doctor. Because you know that in this case right here, these are probably overcoded. Because not every patient coming into the family physician is going to need a level 4 visit. Some patients are going to come in with a simple problem. Well, the doctor went ahead and did this and did that level of history of present illness and did this level of review system. Doctor spent this much time on it and did it. Great. What was the medical necessity for that if the patient's only complaint was gout in the right toe? Or their only complaint was that I've got a little arthritis in this finger right here. There's no medical necessity to check this, 9 body areas. There's no medical necessity to do the review of systems level that the doctor did. And that's what they're going to look at. These kind of doctors are going to get in trouble. Now, I've had a couple of doctors be classified as family physicians. But like I've got a doctor over in Dallas, he was classified as a family physician for many years. But yet all he saw was patients with HIV. That's it. That's every patient he saw was HIV. He was an HIV specialist, an AIDS specialist. Now, that was before they came out with the specialty code for him, and we were able to get a specialty code changed. He was being audited every year. Now, because of the level of service he was doing and the complexity of the risk of the diagnosis the patients had, he won every year on the audit. But he and I both knew he was going to be audited every year. Gastroenterologists. Here are some gastroenterologists that picked out highest level codes, like this guy or this woman, Yolanda Hamilton, gastroenterologist in Houston. 1,605 level 5s, 101 level 4s. That's all she had, level 4s and 5s. Tariq Khan in Venice, Florida. 607 level 4s. It doesn't matter what specialty you pick. Internal medicine right here. This doctor right here, Theodore Ware in Toledo, 587. You're starting to get the feeling of what I'm trying to point out to you. This data is there. It's easy to access if you know how to get in and manipulate numbers and move spreadsheets and databases around. And if I can get it, you know, anybody else can. Pain management. I mean, this doctor had 1,226 level 4s, BLIPs in Stuart, Florida. And I've been to Stuart, Florida, cute little town. I've been to Selma, Alabama. I've been to Medford, Oregon, in fact, to Greenville. Okay, I haven't been to Greenville, Delaware, or Westminster, California, but I've been to 3 of these 5 places right here. And Medford, Oregon is a beautiful spot right on the coast up there, just north of Crescent City. I like that area. But this doctor, pain management doctor, only did 27 level 3s, 603 level 4s. You're starting to get the feel, if you haven't yet. I don't care what specialty, I can pull it up. It's not difficult for me to pull up this data. It's not difficult for Medicare or commercial carriers to spot these. And commercial carriers have their own reports. Now, I don't have access to them the way I do Medicare public data. But you know, if a doctor's billing Medicare this way, I guarantee you 9 out of 10 times your doctor's billing the Blue Cross and the Aetna and the Cigna and all the others the same way. And they're flagging audits. So it's dangerous. Now, when I'm analyzing this stuff right here, I'm looking for different things. Okay, here's some doctors right here that build out level 3, level 4s, level 3s, level 4s. Do you spot anything strange about this? Look at these numbers for just a minute while I take a cup of coffee or take a drink. Look at it closely. This doctor in Colorado Springs, general practitioner, Stephen Winrich. I don't know Stephen. Stephen don't know me. Place of service 0, O for office, 99203, billed out 565 in that year, 2015, charges of 99203 on 543 patients. Yeah. I think some of you are starting to get this already. They had more units than patients. So the next question is, a new patient is one who has not been seen professionally in how long? 3 years. These were all 2015 data. So every one of these doctors right here flagged an audit. And I just grabbed them and sorted them out and said, okay, let's grab some of these right here. That's about 22 times this doctor charged a new patient visit on an established patient. About 21 times there. You're starting to see where I'm going. This is easy to figure out when you're analyzing this product. And way to go, Melissa, on catching that. This stuff is going to get people in trouble. Okay, enough scaring the pants off. This is what I'm looking at, by the way, whenever I'm analyzing practices, or Melissa, like whenever you send me the data, these are the kind of things I'm looking for to help you and your doctors. First, you really need to know the specialty you're working with, because every specialty is going to be a little bit different. And there's going to be billing nuances that's specialty specific. For instance, undercoating. Let's grab this right here. Hussein Yamani in Conroe, Texas, cardiologist. Hussein billed out 2 new patient visits at the hospital. Okay, that's cool. That would be outpatient visits. Maybe he just met the patients at the hospital, convenience for the doctor, not the patient, and saw him in the ER and outpatient department. And then we had 31 times level 2 in the office, 45 level 3s, but no level 4s or 5s. Here's a gastroenterologist, Dr. Spear in Bellevue. Every new patient office visit was a level 3. Garden City, every new patient level visit was a level 2 for Dr. Richard Spinelli. Dr. Favreau, everyone was a level 3. And you can see what I'm looking at. Here's a family physician, Lynn in Nashville, only billed out level 3s, 2s, and 3s. But at the same time, right after that, we had a doctor, every visit internal medicine in Chicago, Illinois was a level 5. This right here really does make a difference on this. These are the kind of things that's going to flag audits or that causes us to lose money. There's no reason. I guarantee you a gastroenterologist is going to see some level 4s. A general surgeon is going to see some level 3s or 4s if they know what they're looking for. They need education. Here's a family physician. Every hospital daily care visit was a level 2, and every discharge was a 99238, 30 minutes or less. Every one of them? Really? Seriously? That's pretty bad. Beth, thanks for that update on that. I need to, well, ask, that's current. That may not work, but I'll look at that. I'll make sure that the PDF that y'all send out, well, Beth Fisher is another consultant and a billing company out of the Northeast, and she corrected me on a link that I had earlier on the OIG Work Plan, but I'll make sure everybody gets the current one. But going back to this right here, you know for a fact some of these cardiologists, some of these neurologists or internal medicine doctor discharges, they spent longer than 30 minutes. More than likely, the doctor does not understand what's included in the discharge. They may think that just the time I spend face-to-face with a patient is counted. That's not the case. It's the time with the patient. It's the time with the patient's family. It's the time writing orders, writing prescriptions, coordinating care, coordinating DME, home health. It includes the time you spend dictating instructions to the nurse or dictating the discharge to the hospital. All of that's counted. If you total it up and it's 31 minutes or longer, that's a 99239. And if this doctor did that 102 times, and we're talking $30-something each one difference, Medicare, and it's probably $50-something difference for commercial insurance carriers, that's well over $3,000 to $5,000 in a year. I know that code by itself may not be making enough the doctor rich, but it might help the office manager pay the bills on time. So this stuff adds up. So it sounds like I'm preaching about just little examples. I'm just showing you little bitty examples right here. Now, there's some people that's better at different specialties than myself. I prefer primary care. I feel like there's probably not any primary care practice in the country. I couldn't help them increase their income by $20,000, $40,000, $50,000, $100,000 a year easily. Just almost every primary care. But that's because that's what I specialize in. But if you call me up and say, Don, I need some help with cardiology coding, probably going to refer you to Terry out of California. She's one of the best. Or if you say, I need psychiatry coding, probably going to say Quinn Buechner in Wisconsin or Sean Weiss out of Doctors Management. Because there's different people in the country that's better at different things than I am, and I'll be glad to refer to you. You really need to know, if you're going to be doing this, what you're looking for. Going back to primary care where I'm comfortable. Whenever one of my clients sends me a report, and this was a sample from one of my clients' actual reports, it showed that they billed out lesion destruction code 17,022 times, and Medicare's allowed amount was $70.83, and they only billed out 17,003 code once. Why is that important? Well, look at the codes. 17,000 is for the first lesion. 17,003 is for the 2nd through 14th lesion. And you're sitting there saying, okay, so what? 17,004 is 15 or more lesions. They didn't bill out any of those. Now, well, why is this so important? Average dermatology billing is when a patient goes in and gets codes removed, lesions removed, for whatever reason. And again, I don't care how you destroy it, by burning it off, freezing it off, snipping it off, cutting it off, whatever. They get 3.1 to 5.4 premalignant lesions removed at a time. So if they're doing this in their office, then I know the patients are coming to the primary care doctors, hey, I've got this lesion and this one, can you take these off for me? The same number. And in this case, this jumped out at me and said, hey, this doctor's missing some great opportunities. They're not telling the billing staff every time they do a second or third or fourth lesion. That's what you should be looking for. Joint injections. Actual report from a client. They had 15 charges on 12 patients of code 20610. Yet you go down there and look at triamcinolone, they had 20 dosages on 17 patients. So we had 17 patients receiving corticosteroids, but only 12 patients were getting charged to 20610 for the injection. This is Medicare data. How did we get that corticosteroid into the other patients? We didn't bill them. It's a lost charge we had. And these are the kind of things we need to be looking for. Flu vaccines. We had 82 charges right here of code Q2038, Fluzone vaccine. but yet we didn't have any G0008. Why? We're charging the patient for the flu vaccine, but we're not charging them for the act of administering the vaccine. That's another $22 in Texas, about $27 in New York, probably $31 in Alaska or San Francisco. You know, two most expensive places, or Hawaii. You know, the expensive places to practice. We're missing charges. This is why this is so important. Look over here. We got J codes down here. If you scroll down and you notice all the J codes we have, J0696, J1040, J1100, J3420. Now look up towards the top up here. Do you see any 96372? No, you don't. None. Over 600 units of injectables. And yet we don't have one charge for administering the vaccine into the patient at about $20-something for each one, or $30-something on commercial carriers. That adds up a lot of money. Venipuncture. This one's interesting. We had 174 draws on 111 Medicare patients. That's code 36415. But yet you scroll down there to 85025, we had 231 CBCs. Now, how do you do a CBC code 85025? It's not done with a finger stick. It's done with a venipuncture. So we did the CBCs on 155 patients, yet we didn't bill out for 111 patients. We only bid out 111 patients venipunctures. So we're not doing that. And there was no charges at 36410 where the doctor comes in and draws it because there was medical necessity. And this doctor has 1,410 Medicare patients. And interestingly enough, we only did 121 A1Cs that year. Look at the A1Cs, 83036, 121 of them on 72 patients. You figure those 121, if we're doing them 4 times a year, that means we have 30 diabetic patients. Yet I know we had 72 Medicare patients, so only about half of the patients got billed for this A1Cs that year. Either that or the doctor's not following Medicare's guidelines and doing an A1C every quarter on every Medicare patient that has diabetes, because that's what Medicare guidelines are. The very first PQRS, when we had PQRS, now I know we have MIPS, but the very first one was they want an A1C on every diabetic controlled every quarter. My wife's a diabetic. She's supposed to go in every quarter and get it done. Now, if it's non-controlled, Medicare, as the second paragraph said, on a non-controlled diabetic, every visit is what it said. This kind of helps me tell the doctor, are you doing what Medicare wants you to do? And this helps me also know, are we going to meet MIPS? MIPS is here. I mean, we're already 6 months into it this year, and there's a lot of my practices that's still not doing chronic care management. And they're going to be wondering in 2019, why am I getting penalized? It's because you didn't listen to me in 2017 and get started with MIPS in time, or you only got a 4% increase instead of a 12% or the 22% increase you could get if you were following my advice. These are the kind of things I'm looking for when I'm analyzing. These are the kind of things you need to be looking for, please. Here we go. 477 blood draws and not one blood test billed for on this client. Wow, 477 venipunctures. Why? What does this tell me? We're sending it all out. Why? You're not doing anything, even clear wave. Doctor said, well, because I've learned you can't make any money on lab. Not if you do it stupid, you can't. If you do it smart, you can. Well, I tried it 20 years ago and things changed. Man, 20 years ago, a lot of things changed. We weren't doing webinars back then. I mean, 20 years ago, I would have been dead based off of what happened last week with my heart. I mean, bam, heart attack, 90 minutes later, I'm out of the lab, coming out of the lab. Total blockage, and yet I'm fine. 20 years ago, I'd probably be dead. Things change. So your doctors have to get out of the Stone Age and change with it. Pneumonia vaccine. Here we got 11 pneumonia vaccines, but not one charge for G0009 to Medicare. So how did we get the pneumonia vaccine into the patient? Okay, we need to be looking at this kind of stuff right here. Here's a good question. Don, what about oncology? We have patients with a main cancer plus metastasis to the bones or brain plus anemias, embolism, etc. They have a cascade of diagnoses. I bill at the highest levels in the hospital and the office often. Can you show an example for oncology? Not right here. I don't have already set up here in my, well, wait a minute. I might be able to. Okay, anonymous viewer, I'm going to try to answer that question at the end and pull up a database live and pull up oncologists and see if we can answer your question live. That'll be fun. I like a challenge, but I'll have to do it at the end because I'm already in the PowerPoint here. So good question. I told you folks, I'm here for you guys. Y'all were there to try to help refuge a lot. You're there to try to help rescue these girls that's slaves here in our own country, that's going through, that's caught up in the human trafficking, sex trade. So because you were helping them, I'm willing to help you however I can. So let's do it. Some people are still following old rules. For instance, they bill out 9305 instead of 93,000. Why? That biller had been around a long time because back in 92, 93, Medicare said they only want you to bill out with 9305 technical. That was only for 1 year's period. In fact, it wasn't even a full year. They changed that back then. How up to date is their biller if all they're billing out is that code? These are the kind of things we're looking for. Spirometry. This doctor billed out 33 times for a breathing capacity test for a spirometer. But they also billed out for airway inhalation treatment 22 times. They never billed for once for a 94060. What is a 94060? That's a pre and post, and it reimburses about 70%, 68% more than does a 94010. That's a big difference there on income. We need to make sure we're billing out the right codes on our spirometers. Here's an internal medicine doctor. This doctor does no ABIs, none. Yet we know that 1 out of every 3 people with diabetes have peripheral arterial disease, and 1 out of every 5 people over 50 have peripheral arterial disease. And this doctor's not doing ABIs. Well, I send them out because I can't afford to do them in the office. A machine to do them in the office is paid for if you're doing 2 a month, and that means everything after that is profit. A doctor seeing that many diabetics and hypertensive should be probably doing 2 ABIs a day. That's an extra $6,000 average net income a month, $72,000 net income a year if they're doing it. These are the things I'm looking for when I'm doing this. Also, I noticed this doctor did 328 motor nerve conduction tests on 39 patients. Wow. These are the numbers that pop up, buddy. I promise you, they're there. Proton, 85610. They did 131 protons on 28 patients. Yet we only had 21 charges on 18 patients and 99211. You sit there and say, wait a minute, should I be doing 99211 each time? Maybe or maybe not. It depends on how your practice does the proton. For instance, if I talk to a practice and I look at these numbers and I ask the doctor, how do you do your protons? Well, I do them after I've seen the patient before the patient leaves. Okay, great. There's not a separate charge for an office visit. Do you have the patient come in and see the nurse sometimes? Well, yeah. And the nurse does what? Well, the nurse will do the proton, and then the nurse looks at my report, the numbers I've said, and if the numbers are this, the nurse comes to me and says, okay, we need to raise it or lower this, and I'll say yes. Great, that's a 99211. What if the nurse just draws the finger stick, does a proton, sends a patient home, and tells the patient, we'll call you on the phone if we need to change it? That's not a 99211. You see the difference. In one of them, we're doing some medical decision making. We're actually doing something that is E&M related with that patient. The other is we're just drawing it, getting paid for the both times, send the patient home. So there'll be times when you should be billing out for 99211 with it. And if you look at the description in the 99211 in the CPT code book, it talks about for blood pressure checks and other things. So maybe we need to be looking a little bit closer when we're billing out the nurse visits. Remember, the nurse is an extension of the doctor. Initial hospital care. Excuse me. What do we got here? We had 37 patients, had hospital visits, 99232, 94 charges on 37 patients. But yet we look at how many patients we had initial hospital care. In this case, we had 11. So 11 patients got the initial hospital care, but 37 during this time frame had subsequent hospital care. How does that happen? Well, more than likely, your doctor is still billing, or somebody in your practice is still thinking prior to 2012. Prior to 2012, the only person that could bill out the 99222 with Medicare was the admitting doctor. In 2012, Medicare changed and followed the commercial CPT rules, which says initial hospital care. First time your doctor sees that patient in the hospital, or the first time that one of your doctors in the same group sees a patient. For instance, Melissa, let's say that Dr. L goes over and sees a patient at the hospital, in initial care. Great, that'd be a 99222. And the next day, Dr. W goes over there and sees the same patient. Well, they're both family physicians, same group number. You would not bill another initial care. You'd bill out a subsequent care. In that case, that would be great. By the way, this doctor was a standalone doctor practicing by himself. That's why these numbers jumped out at me. So make sure you understand and your doctors understand about the rules. Which rules are we following? Pre that or post that? It changes. Medicare rules are different than commercial insurances many times. Like, for instance, global fee periods. Give you a good example. Let's say you do, they put in a cath on me last week, a stent on me last week. Now, let's say I have no complications. I have a 90-day global fee period on that, for instance. But if I have a complication, Medicare, it's included. Commercial, it's a complication. It's not routine, something regular. Now it's not included. We can bill the non-Medicare patient separately. That's what I mean, is there's a different set of rules for Medicare than there is commercial many times. So we need to make sure we're staying on top of that when we're analyzing this data. And I hope this data is helping you. Hospital discharges, as I said before, this particular doctor right here, 33 times on 33 patients, this doctor did not spend over 31 minutes. So if the doctor did, they didn't document it. Don't forget to tell the billing staff whenever you're spending longer than 31 minutes and you document that 31 minutes or longer. What's missing right here? Okay, we have 699 total unique Medicare patients in this practice right here. And we billed out some new patient office visits, some established patients, 99239, only 18 of them. Some critical care first hour, okay, and some flu vaccines. Well, there's a lot of things missing right here. No in primary care practices. No home health agency certifications and research. I guarantee you, out of 699 Medicare patients, this doctor has some patients that's under home health care. And home health care is bringing the reports in for the doctor to look at and to sign. Yes, and those are billable, code GO180 and GO179. In fact, I'm going to do a separate mini webinar on my website, I think, about GO180 and GO179. I'm making a note right now to do that. I haven't done that yet. I need to. Those little mini webinars on my website are like 10 minutes long and they're free. They're just trying to give you little coding tips. What else right here? Well, this doctor right here, what do we got? We had 161 charges for annual wellness visits. In GO180, we had 143 for the initial certification, but no research every 60 days, no GO179s billed. You know that this doctor's signing them. Well, that's not a lot of money. It's an extra $30 to $50-something. Now, what if this was your practice? I can show you a way right now to go back and capture these for the last year. Pick up the phone tomorrow, call the home health agencies that you deal with most often. Tell them you want a thumb drive or you want a CD with a picture of every 485 form that the doctor has signed in the last 12 months. The research and the search. When those come in, hand those to your billing company and say, go back and bill every one of these research, because we hadn't billed for any of them. There's 12 months of it. Not a lot of money, but $37, $38 for each one. If your doctor is doing 5 a week, times 365 or 52 weeks a year, that's 250 of them times $38. Okay, it's not going to make you rich, but there's an extra $8,000. It's going to make you some money. It adds up. Well, no, $3,000. It's going to add up. Here we go. This doctor had 699 Medicare patients, but we only had 15 annual wellness visits out of 699 Medicare patients. Wow. And no alcohol screenings, no cognitive screenings, no depression screenings. If you do the annual wellness visits the right way, the way that I teach you to do it, you have the personnel to do it in your office, you have the people to do it in your office, you should be making close to $400 on each patient. Some of you don't have the personnel to do it. You might need to use a service. Some of you have the personnel to do it, but your doctor just wants to do them all themselves. I had a doctor in Florida send me a report today on a Medicare annual wellness visit. It was obviously an annual physical this doctor was doing. They had not handed the patient all the forms that they needed to, because when that patient walks out the door, they need specific forms. They need PPPS. That's what Medicare requires. They didn't document that the patient had been doing health risk assessment. They had not filled out any alcohol misuse screenings, depression screenings. They had not been doing any cardio therapy. They had not been doing any of end-of-life decisions, 99497. So this particular practice was wondering, why am I only making $134 a patient? Well, it's because they're not doing what I've been recommending they do. I know you can take a horse to water, but you can't make them eat their vegetables. I understand. Do the best we can, but sometimes I feel like John the Baptist, and I feel like I ought to go put on a loincloth and cover myself in honey and eat nuts and go stand in the water and yell, because I wonder if people's listening. Here we go. No sniff discharges. We had, wow, over 500 nursing care visits on patients, over 600 really, if you do the math. And there wasn't one discharge. Not one time did the doctor at the hospital say, I'm sending you to the hospital because you need to spend the night at the hospital because we need to monitor you for this or that. That's a discharge from the nursing home if the patient spends one night away. Look at the reimbursements on a 99315 or 316 for nursing home discharges. This is a doctor in Alabama by the name of Edward. This was his entire report. Edward is a family physician, very busy. I mean, just going constantly. What do you notice right here? Well, not one family physician procedure. I mean, no debridements, no removals, no lesions, no joint injections, no toenail fixing, no removing impacted serum from the ears, not one. No injections, no 96372, no 20610, no injections, no, well, we have a flu vaccine. That's it. No pneumonia vaccine, no HIV, no depot get betters, none of that. No diagnostic testing, not one EKG, not one spirometry, not one ABI. No lab tests, not even a phenopuncture, no 36415s even. No Medicare annual wellness visits. Also, what else? This doctor right here, no chronic care management either. I mean, this doctor right here is missing out, based on his practice, around $280,000 a year. And he's wondering why he's borrowing money to try to help keep his two kids in college. Edward is losing a lot of money. Oh, it's not, and he's not old. Edward is probably, I'd say, about 48 years old. I know him very well. I've been in his practice. I've been in his home. So it's not like he's an old doc unable to change. He didn't know. He was the only profit center in his practice, the only one. I mean, he's not letting his staff be an extension of him. He's trying to do it all himself, and he's missing out literally about $280,000 a year. Oh, we're talking just in 5 years' time, that's over $1 million. No, in 4 years' time, that's over $1 million. And he's borrowing money to try to keep two kids in college. And by the way, his wife runs the practice. She wasn't listening to me. He was trying to, but he wasn't, so they won't do much. It's sad. I've had another practice right here in White House, Texas. Bless her heart. I loved him and her both. She passed away just a couple of years back, and he was having to work the ER just to make ends meet. He's a past president of the National Association of Physicians in his specialty. but she would never listen to me. She always knew better. And they were, basically when she passed away, they died broke. And that's sad to me. Internal medicine, what's missing right here? What do we got? Well, we got a lot of hospital visits, 99223, no, 232 and 33. We got a lot of hospital discharges. So this doctor's spending a lot of time at the hospital. What's kind of jumped out at me on this one right here is not one critical care, not one 99291. You're telling me out of all of these hospital visits, that doctor never had a patient go code blue or turn blue or whatever it was, or do what I did last week, and you have to take care of them on the spot, in the ER, in the office, in the hospital, anywhere? Not one critical care charge. And that's a lot of money. We're talking over $300 on those things right there. And the documentation's easy. Let's say your doctor's in the hospital, and patient goes code blue and stops breathing right here. And the team rushes in, and your doctor's standing there supervising, and they're doing CPR on him. Your doctor's supervising. You've got the 99250. Okay, 99250. No, 92950. Yeah, 92950 for the CPR. Or if your doctor is administering, making sure that the nurses are administering the critical care on this patient, watching over that patient, spends at least 30 minutes. That's a 99291. Sometimes your doctor is spending more than 74 minutes in it, because a 99291 is 31 to 74 minutes. Well, if you're spending longer than that, that's 99292. And yet I know your doctors are doing this. I'm at the hospital with them. I've made rounds with doctors prior to HIPAA, and I've watched what they do. Your doctors need to understand that a lot of things they're doing at the hospital, procedures, they can bill for. I was in a practice the other day, talking to practice the other day. I went into practice. I was talking to practice the other day. They do OMTs. They don't know that they can bill OMTs because the office manager said you can't get paid for them. So the doctor's not doing OMTs. Yes, you can. OMT is osteopathic manipulative therapy. It doesn't pay a lot, but you can still get paid for them if your doctor's doing it. Don't give it away. It's important to know your own specialty. Every specialty is going to be different, as I said. Don't be afraid to ask questions to your doctor. Doctor, did you do that? Doctor, are you doing this? And explain to the doctor the reason you're asking these questions is you're really trying to make sure they're getting paid properly. Don't be afraid to challenge the doctor. The doctor says, well, we can't get paid for that. Don said we can. Would you spend a few minutes on the phone with Don if he can show you how to get paid for that, doctor? And yes, I'll be glad to talk to him. I've been doing it for 32 years now. I'd love to talk to him on this. Don't be afraid to learn. There's all kinds of webinars, all kinds of people, not just me, but there's people out there that can tell you. By the way, if someone ever says you can't do something, make them prove it. Now, some administrators, some doctors are going to believe you. Some are going to need a professional to tell them. And don't be afraid to ask. I'm glad to talk to them for you. We'll be glad to help you pull up the reports on your doctors right here. We have them on our computer already. So I want to try to help you in any way I can. If you want me to, I'll spend an hour on the phone with you and your doctor and your manager. If at the end of the hour, if your doctor believes I just helped them increase their income by at least $10K a year, great, they can write me a check for $500. If not, they don't know me. So I can try to help you. Now then, let's do something different, because our oncology friend, okay, do we get credit for patients who refuse to participate in chronic care management? A lot of patients are refusing. Good question, Catherine. The answer is no. If they're not participating in chronic care management, you don't get to bill for them. Now, as far as credit towards the MIPS, I believe, if I remember correctly, that's going to change next year, that they're going to be asking whether MIPS is going to be giving you credit not next year, 2019. They're going to be given credit if you ask the patient or try to get the patient involved in it. I'd be interested to know, though, why your patients are refusing chronic care management. Let's talk about that for just a moment. It could be because they don't want to have to pay their co-insurance. It could be the patient says, wait a minute, you're explaining to me I need to do this. This is what Medicare wants me to do. This is how it's going to benefit me, but you want me to pay the $8 a month for this. I don't want to pay for it. I refuse. Well, I'd have the patient sign something saying I refuse if you do it in person. If you're doing it over the phone, obviously you can't have them sign it. But what if the patient says, look, I didn't get a raise on my Social Security, costs are going up on gasoline. I live in Los Angeles where a one-bedroom apartment is $3,000 a month, or San Francisco where it's $4,000 a month for a one-bedroom apartment, so I can't afford it. I'd have to do without food. Fine. Have the patient, hand the patient a form, have them fill out a charity form asking for you to waive the co-insurance on that case because they cannot afford it literally. And they'll fill out their income, they'll fill out their monthly bills, and you're going to see they can't afford it. Great. Now then, you've done what Medicare wants you to do to give that patient charity, and you waive the $8 on that patient a month. You said, well, I still can't make any money on it. I just signed up another client yesterday down near Houston with chronic care management on it. They're going to pay $26 a month. In Houston, the reimbursement, I believe, is $44. Even if all they got was 44 times 32 times 8%, even if all they got was a Medicare payment, that would be $36. That's still more than the $28 they're paying chronic care management. And so they're still coming out $8 a head. Am I going to send that to PDF in the video? I'm going to send them both, by the way, Beth. So chronic care management is going to be profitable for you, even if you have to waive the co-insurance on the patients. And yes, you can do that. I think a lot of times patients are getting a call from a chronic care management company, or it could be United Healthcare, is because United Healthcare now owns, I don't know how many hundreds, I think it's 350 clinics around the country. Blue Cross owns clinics, Aetna owns clinics, and they are then doing it as well, and they're calling patients. I think a lot of times the patients are refusing chronic care management because they're confused. They really don't know that your doctor is behind it, or they don't know why your doctor is behind it. I am totally on board with chronic care management myself, and it's not because, yes, I get to make $1 a patient whenever you're doing chronic care management with me. That's not why. I'm totally on board of it because of what I've seen with my in-laws. I'm totally on board of it because I can log on to my chart right now and see any of my reports from last week at the hospital, the reports that I was at, or my orthopedic doctor that I saw yesterday for my knee. And by the way, if you're wondering, my knee replacement's great now. It's a lot better. I'm sleeping at night. And that's good. I can post a question. I posted a question to my cardiologist last week on there, and she called me within an hour on the phone. So I'm a big believer of that. Do you need to use GPPP7 in addition to 99490? Sherry, I'm sorry, but I've never heard of GPPP7. I don't know what that is. Send me an email and I'll look it up, see if I can try to figure it out for you. Okay. Do you have any other questions about what we've already gone over, folks? And I'm going to, while you're asking, I'm going to go ahead and close out the PowerPoint and open up my spreadsheet so we can play with the spreadsheet a little bit, and I can pull up oncology. And hopefully you can see my spreadsheet on the screen. Somebody tell me if you can see the spreadsheet on the screen, please. I want to make sure it wasn't just, there you go. Yep, okay, good, thank you. I see yeses. Okay, so now then, let's go over here and let's do a find. Create new find. And you had a question about oncology. So, and I may have made my own oncology. I think I made a separate oncology. I did. Oncology, I did. I opened up a separate folder for oncologists because I don't deal with oncology very often. How do you obtain the provider data for Medicare? It was a 2.2 gigabyte file. It took me a while to download it, and then I imported it and moved it around. And Teresa, it's very complicated. If you have access, you might be able to use Windows Microsoft Access. I have a Mac. They don't do Access for Macs. So I use FileMaker Pro as a program I bought that I use to break it out on. Okay, so open up. And let's go to browse and open up one for oncology. I hope I have one. I don't deal with oncologists very often, so I don't even know if I made a separate one for oncology. Let's see. Oncology, here we go. Okay, so, and you had a question. I'm going to try to go back up here. ABI, what machine do you recommend? Joy, I am totally on board with the LD Tech right now because the LD Tech is going to do an ABI. It's going to do an ANS test to tell you whether or not the patient's parasympathetics or sympathetics are out of balance. And I'm doing a separate webinar just on ANS testing. I love because I've helped save lives with it. And it does a pseudomotor function testing all at the same time. If you're doing 2 of those tests a month, you're making profit because Medicare's payment on those are a little bit over $300 per patient. Most of my clients that's doing that are making somewhere between $12,000 to $17,000 a month net profit. And I'm doing probably, I would say, 2 LD techs a week right now on those. I love that machine. So call me on that, Joy, and I'll talk to you and go over and I'll give you a little demonstration online about it. Okay, so let's go back over here to our oncology database. Where did it open up here? Oncology. This kind of gives you an idea of what all we can do right here on this. Okay. And I want to go over to the database mode. And you had the question on oncology, how we, office visits. Okay, so let's view this right here as a database. And let's go over and look at the codes for you. Place of service HCPCS code 992-921-21 blank. And this way we can pull them up for just the oncologist and be able to know what every oncologist in the country billed in 2015 and how many times they billed each code and how much they billed for each code and what their total payments were from Medicare, et cetera. And we're going to find whether or not which doctors billed out the highest levels, et cetera. Now, I haven't run all the percentages yet, but this is the data that I'll have based off of every claim to Medicare in 2015. Can you bill out the highest levels for the office and the hospital? Yeah, if there's going to be times when you can, due to, as you said, the metastasis and the cascade of diagnoses. But there'll be some patients that you shouldn't. It's all going to average out based on the national average for your specialty. What I have calculated out, I'm going to show you on the screen right now, is I've calculated out for 2014 data for every one of these specialties. And as you can see and I don't have any oncology clients, so I didn't run it for that year, but I'll run it this year for 2015. That way you'll be able to get this file if you need it. Now, this is not something that I do for free. I think it's not much. I think it's like 50 bucks or something I charge for this because it includes all the specialties, or 70 bucks. It's just based on how much time I spend doing it because this is a lot of work to try to calculate it out for all of these codes for all these specialties. And I'll make that available to you, anonymous viewer. Okay. With ABI, yes, we can see it. The idea, okay. How do you obtain the provider data? I told you that it's really, where do you find the data? It's on CMS's website. There's a link you go to download the 2.2 gigabyte size file. I can send you a link on that, Teresa. Again, I highly recommend you have Access or FileMaker Pro. Those are the only 2 that I know that will handle a file this size, unless you have some other database program you prefer. So send me an email and I'll send you that link, Teresa. Okay, so what other questions do y'all have? Because I've kept you guys an hour and 14 minutes so far, but I'm not in a hurry. My time is yours right now. So what other questions do you have? We haven't lost any participants. Wow, everybody's still here. I like that. So everybody's here. That's cool. So how many, what other questions do you have right now that I can help you with? That was on the analytics. This was on the people here. This was on oncology. This was on all the data on every doctor in the country, which I'm showing right now 5,399,000 rows of information still left on this spreadsheet for me. That's a lot of rows with a lot of data. Folks, I hope this stuff is helping y'all. I really do, because that's the whole idea of putting this thing on today. Not that I'm trying to confuse you. I'm trying to keep this right here as simple as possible for you. Anything I can do. Why aren't more of us RAC auditors? It seems like that the payment would be, why aren't more of us RAC auditors? It seems like the payment would be significant. Oh, it is. I've got approached in the last 4 years. I've been approached by 3 different RAC companies to go work for them. The payments was very nice. I have a problem going to work as somebody else and working on that side is my problem, Becky. With the data that I have, could I just not go get in contact with one of the many attorneys I know and start filing key TAMs? I could. That's not what I want to do. Have I ever turned doctors in for fraud? Yeah. Probably about 5 times, I'd say, in the last 31 years. I've done work for doctors, and I've told the doctors, you're committing fraud, you can't keep doing this. And the doctor said, no, the money's too good, or I'm going to keep doing it, or you can't tell me what I can and cannot do. And I've refused to take a paycheck from them, and I've turned them in. Why? Because it's my money they're stealing. Y'all understand, I pay a heck of a lot of money in taxes, and I'm not going to let somebody rip everybody off doing something illegal if they know it's illegal, and I tell them it's illegal. So why not more of us RAC auditors? Some of you will be. Some of you are going to sit there and look at this and say, crap, the data is there. If I can mine this, I could be filing key TAMs, hundreds of them a year. My income would be several $1 million a year. Trust me, I've thought about it. I won't play on that side of the fence. Y'all probably don't realize this, but I walked away from a company in 2014 that I had earned, my commissions were up to $50,000 a month, $600,000 a year. And I walked away from them that I was working with because I felt like they were doing things unethically and immorally, and it just wasn't right. It was legal for them to do it, but I walked away. So money is not going to be my God. So that's why I think, Becky, why I'm not. I don't know why more folks watching this are not RAC auditors. But like I said, I've been approached, and I'm not interested in being one. Nina, chronic care, would malignancy cancer be considered chronic care management? We see many patients in the hospital with chemotherapy administered by the hospital. I'm trying to capture the time the doctors spend putting in orders, monitoring their labs. It's all non-face-to-face time. There's other codes we might want to look at, Nina. You and I need to spend some time on that. It's not going to be an easy answer right here I can pop out for you. If you give our doctor, can you send us their info that you have and maybe suggestions of what they can do? Of course I can, Tom. In fact, if you were to give me a doctor right now, I'd pull it up right now and show you some of the data. It's that easy. Verify serum removal. Does it have to be by a physician to charge this? Good question, Catherine. Let's talk about that. And yes, Tom, I'll be more than happy to do that for you and your client. Let me go over an idea with you in a moment. Catherine, you got 2 main codes for 6.9 for removal of serum. One is by the doctor doing it, or the nurse practitioner or PA doing it. In other words, a practitioner doing it, using a tool, and you must have impacted serum as a diagnosis. Okay. The other is the nurse doing it with water, and that's code 69209. That one does not have to be done by a doctor or a nurse practitioner or PA. That can be done by a nurse, an MA, a CPA, the receptionist, anybody in your office, as long as the doctor's on the premises. 6.9, the difference is on those codes, by the way, 69209 is per ear. Medicare 69210 is one charge, whether you're doing one ear or both. You can only do multiple charges of 69210 if the patient has 3 ears. But if you're talking 69209, removal of serum by lavage, water, that's per ear. You'd have a 69209 LT, 69209 RT. That can be done by the nurse. And it's not a lot of money. I think it's like $9 or $11 for each one. Okay, that answers that question, Catherine. Tom, what I have a lot of billing agencies do will schedule a time for me to spend an hour on the phone with them and their client and their client's manager. And I'll pull up the data just like I'm showing you right here. At the end of the hour, I'm going to ask that doctor, did I just help you increase your income by at least $10,000 a year? If the doctor says yes, they can write me a check for $500. Sometimes the billing companies will sit there and say, hey, I'll send you $250. The doctor will send you $250 because you just made my client $50,000 and that makes me more. That's cool. If the doctor says, no, you did not make me any more money or did not increase my income by that much, then that doctor doesn't owe me a penny. Now, let's say, though, that you're the office manager of a practice and you want me just to pull up the data and give you suggestions. Yeah, I can do that. I do that several times a week. At least I was, before the heart attack, I was doing them typically 3 to 5 times a week with practices. Now I'm kind of slowed down a little bit. I still don't mind doing it. I'm still sitting right here at a desk. And I don't have another plan to travel right now till the middle of July when I'm speaking at the Texas Rural Health Clinic Association Convention in Austin. And then I'll be in September, I'm going to be at the American Academy of Family Physician Convention in September in San Antonio. And then in September after that, immediately after that, I think we're going to head up to Connecticut, New York and Connecticut, Vermont and Maine, and maybe go into Canada because my wife wants to go up there and see the leaves change. So I'm going to try to schedule a couple of seminars up there in Maine and Vermont or New Hampshire or someplace. I think Linda is going to help me schedule some of those, and somebody else is as well in Connecticut. Try to schedule 2 or 3 of those up that way so I can ride off the trip. And we'll pull the RV up there and go into Canada. I have to leave my guns at the Canadian border because they won't let me carry my guns across. Well, my shotgun I can carry, but things like my pistol, they don't let me carry that into Canada. They make me leave it at the border. So. Okay, so any other questions right here? Okay. It's been 1 hour and 22 minutes. You guys have been fantastic. I love the questions you've asked. Thank you, Melissa. I am totally blessed. Thank you for all your prayers for me. I've had an amazing number of people out there praying, and I always heard that after a heart attack, people get a little bit more emotional than they were before. And I've figured that out is true. I've been that way. Thank you, Nina. I really hope this has helped you. Any other questions, folks? I'm going to send you all a link. I'm going to change that link, by the way, Beth, on the OIG watch list because I want to make sure that everybody has a current one. And I'm going to do some more of these webinars, too, for charities. I'm a CASA, Court-Appointed Special Advocate for Kids, and in fact, at 5:30 today, I'm supposed to have a thing I'm going to raise awareness about CASA. Becky, you've been a blessing to me. Thank you. Teresa, I appreciate y'all. No other questions? Then I will close this out and compile the PDF and compile the changed PDF. Thank you, Beth, on that. And change I'll compile the movie file, and then I'll upload that to share file, and then I will send everybody the link. Please take the poll that I'm sending out because that helps me know how well I did and what I need to work on. So please take the survey I send you, in other words. And tell others about me because that's how my business grows. And Joy, seriously, that you and I talk about that LD Tech. I think it would help you guys great. And I think the excitement I have on that one is how it's going to benefit your patients more than anything else. Yeah, the money is great, but you're going to help save lives with it. And that's what I get real excited about. I've had doctors tell me that they sent patients to the cardiologist and said this patient's going to have a heart attack in the next 72 hours. And the patient had one sitting in the receptionist's office. Dr. John Gelwaller has told me stories about that right there. I've got Dr. David Braunreiter, past doctor for the Houston Texans, told me stories about when he was the team doctor down there. He sent patients to cardiologists, and they were amazed at what they were able to capture because a family physician said that to them. Same thing with Stratton Douglas up in Texarkana, Jeff Reddick over in Gainesville, here in Texas. doctors swear by these things. They save lives. So I get excited about that. I'm no longer just trying to help doctors make money. I'm restoring quality of life to patients whose sympathetics and parasympathetics are so out of balance that they're so always fatigued. So, Joy, you and I can talk about that. That's an area I get excited about. And I can actually talk medically in that area because I've been studying ANS testing since 1999. No, I don't have clinical training, people, but I get excited about that. So, and that was even before the heart attack. I got emotional about it. So, anyway, people, thank you so much for being part of this, and thank you. I cannot thank you enough for helping Refuge of Light. Just a little bit of money you might have gave, or a bunch of money you gave, might help them rescue one teenage girl away from the sex trade and help them have a normal life and get counseling and get into a regular family life. So thank you. Thank you very much.